By participating in research, you help us doctors and scientists answer the big question. Your involvement helps us to come up with real-world solutions to make healthcare better for everyone. Diversity in research has real clinical consequences, and Dr. Tal Valley here is a physician scientist who takes care of critically ill patients. Is going to give us an example of how racial bias in research can impact healthcare directly.
Can you guys hear me okay in the back? Great. I just want to say how lovely it is to be here with you all. We are truly appreciative of you allowing us to participate in research as a result of what you've provided to us. Now, I'm going to be telling a story today. The story centers around pulse oximeters, but really this is a story of the University of Michigan. This is a story of COVID in Michigan. This is a story of you and what you've provided to us and allowed us to be able to do as a result of the data that you've provided. How many people have had their oxygen checked by a pulse oximeter here? Pretty much everyone, right? And think of all the important decisions that are made as a result of those data, right? It might just be on your watch and you're just checking it for fun. It might be you're going to see your doctor and they're just checking it routinely. But it also might be in the height of COVID, you're at home and you were told to buy a pulse oximeter because you had COVID. And your doctor told you to only come into the hospital if your pulse oximeter read a certain level. Right? It could be that you're in the emergency department and they're checking your pulse oximeter value and they're deciding whether to send you home or not. Right? These are really important decisions that come about simply because of this number from a pulse oximeter. And for decades, the pulse oximeter was created in the 1970s. For decades, we've used that number on total blind faith. Right? It spat out a number and we said, okay, that's what your oxygen level is in your blood, and we believed it entirely. But it wasn't until COVID that we started to question that number. And I'll talk to you a little bit about that story. So as we know, a pulse oximeter, typically we clip it onto your finger. It sends a light across your fingertip, and then it reveals kind of how much oxygen is in your blood as a result of that light. It's highly technical, but it's a number that we depend on every day in the hospital. I take care of critically ill patients in the ICU. We are constantly monitoring a patient's oxygen level using this device. And we're making life or death decisions entirely based on that number. But you could imagine if it's sending this light across your fingertip, what happens if you have darker skin? Right? What happens when that light goes across your finger and maybe you're wearing nail polish? You would envision that that might affect that number in some way, right? It's pretty obvious now thinking about it, but yet for 50 years we didn't really think too much about it. There were some studies from the 1980s, 1990s that did show there were some differences, that black patients might have had a little bit different pulse oximeter values. But the conclusion, the takeaway from all those studies was, it probably doesn't make a big difference. And yet, there are other common areas where we see these types of problems. For those in the back who can't see this, I'll kind of describe it. There's a gentleman with darker skin who's trying to use this soap dispenser. It's not sending out any soap. So what he'll do next, it's not sending out any soap. What he'll do next is he'll get a piece of white paper towel, put it over his hand, and look how quickly it delivers the soap. He gets rid of the paper towel, gives out soap again, gets rid of the paper towel, sticks his hand back under, no soap. This happens routinely. But there's a big difference between a soap dispenser and what someone's oxygen level is in their blood. So what we saw during COVID, so like I said, we've been using this pulse oximeter for decades, right? But we didn't really think too much about it. We just trusted this number. there was something specific that happened during COVID, particularly at the University of Michigan. First, typically in our ICUs, we take care of probably around 80 to 85% white patients, and then probably about 5 to 10% black patients. During COVID, we had a dramatic switch, right? Very early in COVID, we probably had 80 to 85% black patients in our COVID ICU. So we were taking care of a lot more patients with darker skin tones, and all of those patients in our COVID ICU were having this special device placed into their wrist that could quickly take out your arterial oxygen, quickly take out your arterial blood. And that's the gold standard for checking what someone's oxygen level is in their blood, right? We check your arterial blood, but we didn't routinely do that. But in COVID, we did, because we wanted to make these decisions quickly. We wanted to limit time that people were spending in the hospital room. So every patient who came into our COVID ICU had one of these special devices. And then they also had a pulse oximeter. And so for all these patients, we were getting simultaneous measurements of what someone's oxygen level was in their blood and what the pulse oximeter was showing. And all of a sudden, we were saying, hey, wait a second, like, these numbers don't match up. What's going on? And for a while, actually, we thought it was just a COVID thing, right? We didn't put two and two together initially. We said there must be something funky about COVID, that it's causing this mismatch between this device we trust all the time and what someone's true oxygen level was. And it wasn't actually until a couple months later that it kind of dawned on us that, hey, this isn't COVID, this is the color of someone's skin. And so at first we were just thinking about that in terms of the patients we were taking care of, but we couldn't really extend that out more broadly. But thanks to you and the data that you provided us, you gave us the opportunity to look at that at a larger scale. Very quickly realized that we had an opportunity here that very few people around the country actually do. We had access to nearly 1,000 patients, 250 black patients, 750 white patients, in their simultaneous levels from their blood and from their pulse oximeter values. And so very quickly, we could go back and look, hey, is this just a COVID thing, or could this have gone on way before then too? And so what we did was we looked here at what someone's pulse oximeter value was. If it read as normal, how many people actually had a low oxygen level, a dangerously low oxygen level that they should have been on oxygen for? And thanks to the data that you provided us, we were able to look at this very quickly. And we saw, hey, what we were seeing at the bedside was actually true before too. And so what we found, this is from our study, which was published in the New England Journal of Medicine. We used data from the University of Michigan, like I said, about 1,000 patients from the University of Michigan, and about 10,000 patients from 180 hospitals around the country. But the first study we did was here at the University of Michigan to see if this was actually a thing. And once we saw that this was a thing at the University of Michigan, we also did this study in this 180 group hospital system. And what we found were that black patients were 3 times more likely to have low oxygen levels missed than white patients. I mean, think about that. 3 times. So 15% of black patients' measurements looked normal, but were actually dangerously low. And these pulse oximeters weren't perfect for white patients either. 5% of the time, we were missing low oxygen levels for white patients too. And I think this is kind of the key takeaway to me as a clinician. When you look at the bottom here, we have your pulse oximeter value at 89%, 90%, 91%, 92%. On the right here, we have kind of your true blood levels in your oxygen levels in your blood. What you can see is that when you get to a value around 91%, the red is for black patients, the blue is for white patients. When you get to a value around 91% on a pulse oximeter in our data, more than 50% of black patients had dangerously low levels. And generally, when I'm a clinician, I don't start a patient on oxygen until they have a value below 88% on their pulse oximeter. So that's a lot of black patients who should have been on oxygen that weren't as a result of our data. Since we published this work, there have been several other studies from groups around the country who've shown the exact same thing as us. There have also been studies that have taken the next step, something that I never envisioned would happen. They've shown that Black patients had a higher risk of organ failures. They've shown, not surprisingly, Black patients got less oxygen. They showed Black patients had higher risk of death. And they showed that Black patients were less likely to receive life-saving treatments for COVID as a result of these problems with pulse oximeters. This is big, this is important, this is a problem. As a result of you, we've been at the forefront here at the University of Michigan in trying to fix this problem. We've talked to the FDA, we've testified to Congress, senators have written letters to the FDA about this problem. We've been working with the Veterans Administration to try to fix this problem. It's still not solved. We still don't have a pulse oximeter that has fixed this problem, but we're working on it, and it's entirely as a result of the privilege that you've provided to us in working with your data. So I want to thank you. I want to thank the co-authors of the study. We are truly appreciative of all that you've provided to us. Thank you.